herbs and supplements and things like that are powerful, but pharmaceutical intervention, usually can't be matched that way. And that is a two-edged sword.
Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi there, welcome to this week's episode of the Dutch Podcast. I'm really thrilled you're joining me today because we have our founder and CEO, Mark Newman, on the pod to talk about a recent publication that we put out in October of 2025. This is a really cool publication because it's a case study. It follows a clinical case of a patient, hint, hint, it's actually Mark, and follows it through what happens for a patient who wanted to support testosterone. In this case, the patient was given HCG, but we get to see a baseline with a low level of testosterone, and then the addition of HCG, and then several rounds of supplements, and he tested after each round. So what's so cool is you can actually see how you might utilize the Dutch test clinically with patients who are on testosterone replacement therapy. And now we don't recommend that you do Dutch testing to monitor therapy. However, what you're going to walk away with is just how much extra information you can get from the Dutch test to augment the monitoring you might do through Serum. So really cool case. I don't want to keep you waiting. Let's start to nerd out and bring Mark in. So Mark, thank you so much for joining me today to talk through this really cool case and case report that we published.
Absolutely.
So just to frame it up, this case, if you want to read the case, it's open access through Integrative Medicine, a clinician's journal, or IMCJ, and we published it in October of 2025. And the really interesting thing about this case, and I just want to put this out here before you really walk us through, is that we've been looking a lot at the use of testosterone. Of course, we measure testosterone, we measure other androgens and androgen metabolites on the Dutch test, but we've been thinking a lot about how testosterone is monitored. In fact, we have a review paper coming out quite soon on testosterone monitoring, comparing different ways that it's monitored. And one of the things that's just takeaway finding on that is that we don't recommend Dutch tests as a primary way to monitor dosing of testosterone. But I'm excited to kind of pair that with this case report because this case report really shows why people utilize Dutch testing, even when it's not to monitor the hormone. All of the other benefits that you can get or learnings that you can get out of the report. So hopefully I've painted a picture well enough for you to kind of jump in.
Yeah.
But why don't we start by just talking through the case and what we outlined. So if those of you you like to listen, you like to see, this is a great one for you to check the video. If you're streaming this, just audio only, you might want to pull it up on a streaming service with video because you're going to see the report in person, but you can also check it out in the printout. So yeah, walk us through this case.
Yeah, it's a case that I know fairly well because it's me. And it's also a nice case for us because we talk so much about, and rightly so, women's health and the use of the Dutch test. We talk about HRT. A lot of the arguments about HRT circle around this issue of like, where do I want to hang my hat when it comes to doses, when it comes to, am I ready for my next dose, those types of questions. And sometimes the Dutch test is in a great position for that, and sometimes serum testing is better, as you sort of alluded to, with testosterone, and particularly for men. Did I get the pellet dose right? Do I need a new pellet? Did I get the injection dose right? Transdermal, whatever it is, serum usually is a really good way to monitor that. And we promote Dutch test in that scenario for its complementary utility. Like it complements serum in that sense, which is not a rare space for Dutch. I mean, we don't test thyroid on the Dutch test, but because of how much crosstalk there is between thyroid and adrenal, they're a great complement to each other. So there are spaces where serum testing and urine testing can compete with each other, but they're really the greatest utility is for people to have both of those in their toolbox. Sometimes you need one, sometimes you need the other. When you put them together, you get really, really interesting data. And this is one of those cases. I don't have the serum data here to share along with it, but that was something that was also being monitored, along the way, was serum testosterone, serum estradiol, what does LH look like, some of those things. But, in this case, what we have is a male patient who doesn't have, overt testosterone deficiency, but is low relative to the young, healthy range. You can see for the men, if you're not familiar with the way we represent men on the androgens, in the females, we've got the purple band that represents the postmenopausal range, and then the green band that represents the luteal range. And for estradiol and progesterone, those are really well separated, which we make a big deal about. But for androgens, the biological reality is there is overlap between what's expected for a 61-year-old not cycling woman who's not on hormones and a 26-year-old woman who's cycling and young and healthy and all of that. There's overlap between those. And for the men, what we have is our two age groups that make up sort of a similar look for the androgens, which is in this example, as you can see, is what's normal and healthy for a man who is in the age range of 40 plus, is that 25 to 80 range. And what's normal for a young, healthy man who's, 20 to 40 is that range of 40 to 115. So you can see both of those ranges. There's a little bit of overlap. In this particular case, we're just a little bit below the young, healthy range, which correlates well with the serum free testosterone. So this would be like a low normal testosterone. There's a slightly elevated SHBG, which is, again, a reason why you need serum testing, is you can't tell if we just have lower production, or is there SHBG that's gobbling up that total testosterone and leaving the free a little bit on the low side. That would be the situation here. And so when we talk about urine and testosterone or estrogen, we talk about it reflecting bioavailable hormone. I think that's a good description of what we're looking at here, which is on the lower side. Okay. So then as we look at the estrogens, you can see they're perfectly normal. Estradiol is right down the middle. Estrogen's a little lower than that. This is somewhat unremarkable, except the methylation is on the lower side. So as we convert 2-hydroxy to 2-methoxy, that's on the lower side. I'll show you why that is in a minute. But first, we're going to make it worse by adding into the picture testosterone. So when we talk about TRT, sometimes we're talking about an injection. We're talking about, a transdermal, a pellet, whatever it is. In this case, we're talking about increasing endogenous testosterone. Now, how can we do that? There are two main ways that I'm aware of. Well, I should say three. One is lifestyle, right? Do your deadlifts and get good sleep, whatever. I just was listening to someone this morning saying, taking cold plunges and then doing your workout, you can double your testosterone. Great. Like, those are good conversations. Lab testing can be a great way to see, like, hey, how well did that work? Fine. But when you're talking about intervention in terms of something that you're taking, you can take enclomiphene, which is you would speak way more, like, what's the typical use of enclomiphene in a female as it relates to fertility? Maybe you could just describe its normal use, and then I'll describe the male use that's aside.
Sure. So, just to comment on the lifestyle stuff, definitely is really important to handle that before you layer on exogenous testosterone, in my point of view. Because a lot of things, like if there's sleep disruption or sleep apnea, or high levels of stress, you're going to have a more difficult time raising testosterone levels with external testosterone and finding patients that benefit from it. So keep that in mind. So when it comes to clomiphene citrate, typically you'd be looking for women, they'd be using it about 5 days during the cycle, during the time that we're stimulating follicles to develop. And you're looking at like 50 milligrams or 100 milligrams typically.
And that helps them make?
Oh, it helps them mature follicles. So what it does, it actually blocks the feedback mechanism to the brain so that the brain does not sense that estradiol is being made by these follicles. And so then the brain turns up the volume on follicle stimulating hormone, and it essentially is a way to get FSH higher so you have a louder signal to the ovaries. So you have follicles that are kind of overproducing, essentially. It's a way to stimulate follicular development.
Perfect.
So it's a really nice, and there's, of course, this, where you're headed, is that this happens in men with the testes as well.
Right. So the signal, perfect. Thank you. And then for a guy, if I have too much estrogen, then that's the signal that says, hey, I don't need to make more testosterone. And so if you use enclomiphene, then it helps the body to produce LH, which tells the testes to make testosterone. That's an option. Another option is to take an LH. So enclomiphene helps you make LH. LH is a signaling hormone, but LH is a cousin or sibling or something like that. It's an analog to HCG, or HCG is an analog of LH. So in this case, what we did is HCG was used. So you can see the testosterone goes from 39 to 76. We got the expected response from the testes. And then what we see here is that, oh, bummer, there's too much estrogen. But this is where the urine testing is interesting, is it's not just, hey, your estradiol is high, hey, your estrone is high. The way I would describe this is if estradiol and estrone are high and things are normal downstream, then those downstream metabolites should be proportionally about as high. So I would expect, for example, 2-hydroxy-E1 to be more like 6, 7, 8, and likewise with the other compounds. But what this is a picture of to me is I'm increasing testosterone, aromatase is making estrogen out of it, and then it's kind of stuck. The downstream metabolism isn't really happening. Yes, you can look at the ratios of those, and this is on our new report. One of the advanced insights that we point people to is if you just see parent hormones high, daughter hormones or metabolites not high, then there's a generalized sluggishness to that clearance. And then you can also see that the methylation has gone from what it was before, which was at the 20th percentile. Now that ratio has lowered, so I'm at the 12th percentile, so my methylation stinks even more. Okay, so
Can I talk about this a little bit on why this matters clinically? So, I mean, here's the thing when it comes to getting men on testosterone, and this case, the patient took HCG. You took HCG. The same thing can happen if you're taking any kind of testosterone analog as well. So just want to highlight that. And even Clomid, anything that's going to drive testosterone up, you're going to be pushing the excretion pathway, which estrogen is one way that testosterone is essentially excreted from the body. You can think about it as a metabolite, along that pathway for testosterone because it gets aromatized. So when men tend to have high estrogens, it actually can feel a lot like low testosterone clinically. And so it's a really important thing to be, one, separating those out. And if you have patients that their testosterone is within the normal range, male patients, but they are feeling low libido, low energy, brain fog, mood suppression, having trouble building muscle mass, all those things that would lead you to say, this patient's classic low testosterone. It's also nice to check estradiols because if testosterone's in the normal range, but estradiol is proportionately higher, you can think of it as like a male estrogen dominance. It's very difficult for men to feel better. So this is really, really important because you don't want to have a clogged metabolism or a clogged drain in those estrogens. And that goes even before we look at the impact of estrogen metabolites on DNA. This is really just the estrogenic piece of it. So it's a really important thing to make sure that that clearance is happening. Particularly, I'd think about it in men where they're on testosterone, but they're just not feeling the way that you would have expected them to. And this is a great case when you can look at the results and see why that is.
Yeah, no, that's a good point. So one of the strategies you could take, which is super common, is just dose an aromatase inhibitor. So not putting any judgment on that strategy, but what I'm telling myself in that case is I'm just making too much estrogen. But if I first identify that, well, hold on, like your estrogen clearance stinks. So maybe it would be worth addressing that before you go and pharmaceutically block the conversion of testosterone to estrogen, which you don't want to overdo because if you have low estrogen, you're going to have other types of consequences, which we could talk about. But let's look at what happens here. And I should say, what I'm doing here is because, hey, guess what? We own a lab, so we can do a whole bunch of extra testing. I'm not proposing that at each step you necessarily intervene, test too much, but I was able to do that in this case to see how stepwise this worked. Because in clinical practice, what you'd probably look at here is say, hey, my methylation stunk. Now it's even worse. I want to address that. But what we did here is we said, let's go one step at a time. And so if you look at the next set of results, we introduced something to increase that clearance of estrogen down that 2-hydroxy pathway that was sort of blocked. So you can see if I go back and forth here, the 2-hydroxy-E1, well, let's look at that there. The testosterone is almost identical. From 76 to 75, you should not always expect that level of precision. Like biologically, it's going to bounce around a little bit. These happen to be just like dead on the same. Okay, then estradiol, I lowered it by adding DIM as well as calcium D-glucurate. So we'll talk about that in a second, but you can see the estradiol went from 3 all the way down to 2.1. Now, 2.1 is still right at the top end of the range. And what did I do to lower that? Two things. One, I increased the 2-hydroxylation by adding diindyl methane. We've published on this, and this is one of the reasons why we like to publish a case study, because we've already published population data. Now, that was in women, but I think we have at least 3 publications that have said, hey, if you have estrogen at a particular level and you increase the 2-hydroxylation by taking DIM, it will upregulate 2-hydroxy-E1 and it will pull down those parent hormones of E1, E2. That's on a population. At an individual level, that doesn't happen to everybody, but it happens on the whole. And then at an individual level, that's, the type of medicine that you're doing is on an N of 1. And so on this N of 1, you can see that my 2-hydroxy-E1 went from 4.6 all the way up to 8.7. So a massive increase in 2-hydroxylation. The other thing that we're doing here that we don't want to ignore is we're also helping the body get rid of the estrogen by way of sort of phase 3, which is you have estrogen, you turn it into estradiol glucuronide, estrone glucuronide, and then as it goes into the gut, that gets a chance to recirculate if that glucuronidase happens, where the glucuronide turns back into the parent estrogen. And that process itself of cleaving that for recirculation is blocked by calcium D-glucurate. So this product says, hey, we're going to help you get rid of the estrogen through the stool, and we're also going to push it down the 2-hydroxy pathway. So it's a 2-prong approach with this product from Orthomolecular. A lot of people sell DIM products. I think it's a little smarter to add the calcium D-glucurate, because why not, if you have high estrogen, why not help get rid of that clearance as well? So estrogen comes down from out of range to barely in range for the estradiol. You can see the estrone is comfortably within range here, but maybe that's a little too high on the E2. But what we also saw is that my methylation that went from bad initially to worse to like, what in the world is going on here? Terrible. At the
Yeah.
4th percentile. So
Yeah, Mark, you're good at a lot of things, but methylation is just not one of them.
yeah, I am not a renaissance man in terms of being good at a lot of things, if you include methylation. So, and again, we'll get to the why in a minute, but what have I done here? And this was really interesting to me, is that I didn't really know how to think of methylation in the sense of, like, it's methylation that goes on everywhere, right? So in my head, if I increase 2-hydroxylation and I've got more catechol estrogens, like, who cares? There's methylation going on everywhere. Is it possible that I'm overloading that COMT enzyme with so much substrate that it can't methylate? Like, my thought would be no. But clearly, at least for me, you can see that methylation capacity goes way down when I increase all that substrate. So that's pretty interesting.
Yeah, it's so interesting. And so I want to just slow it down a little bit. I mean, what we're seeing here in the kind of let's say the pre-test and then the post calcium D-glucurate and DIM test is that one with the HCG, you did get that bump in testosterone that you'd expect. But with that came along a lot of estradiol, and then it clogged up the drainage system for the estradiol and really negatively impacted methylation, because you just had so much more substrate that had to be methylated and eliminated. Right. And that's a different problem, right? Because we want to make sure there are enough methyl donors around and that the methylation capacity is sufficient. And we talk about this a lot when it comes to any kind of hormone therapy. It's relevant for women who go on estradiol as well. You want to make sure the body can appropriately eliminate. Otherwise, you see this screaming high estradiol that's going to impact the way that man feels. So there was another next step that you took to really help to really focus on methylation to keep that pathway moving forward.
Right. And starting at the top, again, the testosterone's pretty steady. It's from a little below 40 to mid-70s, mid-70s, mid-70s at all 3 of these steps, and then just getting that downstream picture better. So then we added in trimethylglycine. So now I've got HCG still in the mid to high 70s for testosterone. My estradiol went from over 3, I think, to 2.1, and then now down to 1.7. So I've pulled it down lower, and I'm still on the DIM, still on the calcium D-glucurate, but now you can see the methylation has dramatically improved by taking trimethylglycine, which is helping create that methyl group so that COMT is able to do its work better. So now that substrate of 2-hydroxy-E1 is no longer up around 9. That's pulled down as well. So you have this overall balanced picture with what you'd call still like a high normal estradiol, but more comfortably within range, and then much more appropriate phase 1 as well as methylation or phase 2. And so you can see the stepwise individualized care there. And what we're trying to do is obviously have better outcomes because we want to feel well, and you're less likely to do that if you have something out of range like an estrogen. But the other thing is just in terms of risk is if we're not methylating catechol-estrogens, and if we have too much estrogen, then, if you just snoop through the literature on prostate cancer risk, for example, that's not a good combination to have there, particularly if you go back to the other one, you can see that the 4-hydroxy-E1, it's within range, but it's on the higher side. So if it's on the higher side, I'm a little uncomfortable. But then I know the way I get rid of that is by methylation. So if my methylation really, really stinks, then that 4-hydroxy is around to do its work. Now that I've added in both more effective methylation as well as increasing the other detox pathways, now the 4-hydroxy is even more comfortably in range, and I can be more confident that it's being methylated better because because I've increased my methylation, which if you look here, what we're looking at, if you're not familiar with this, is the 2-hydroxy to 2-methoxy. We're looking at that ratio, and I'm just right about dead center on this one, which means I'm pretty much average. And for me, average is great because I've got a genetic homologous SNP that I think impacts methylation by it makes it like a third. So I've got a genetic test here. I've done a few of them in terms of a few different interpretations of the way that's presented. I don't remember which one this is, but you can see that I've got the red there says this is a problem in terms of genetics. And these are all of the ones that have to do with methylation. Now it's listed as neurotransmitter pathway because that's also how you process dopamine and epinephrine. But for the estrogen, if I'm not good at COMT activity, then that's going to be a problem. And you can see here the methylation activity, which is just that ratio. You can see it going from the 20th percentile. Then I increase the estrogen. Now it's the 12th percentile, so more substrate. And then when I add the DIM, it just tanks it. And then now I'm bringing that back by increasing the methylation. So it's a fun little case study.
What a great case study.
And one worth paying attention to because your individual patients, as you increase their testosterone, whether it's from a cold plunge and working out or from enclomiphene or from HCG or from an injection of testosterone or pellet or whatever, has the potential to have these cascading issues. And, you mentioned stress and some of those things as well. This is the complementary benefit of the Dutch test, is to look at the HPA axis, to look at testosterone metabolism to see how much DHT someone's making, which we didn't show here. And then looking at that estrogen cascade as well is really valuable information, because if this is going to be you, in this case me, for 6 months or 6 years, in terms of our risk for negative outcomes of many types, these are the types of things we can do to put us in a better sort of risk profile.
We'll be right back with more. If you're already running Dutch tests in your practice or thinking about it, there's never been a better time to become an official Dutch provider. Why? Because we go beyond lab testing. Our provider community gets exclusive access to clinical education, in-depth report interpretation, training, monthly case reviews, and one-on-one clinical support. Whether you're just getting started or looking to sharpen your functional hormone expertise, we give you the tools to grow. Join thousands of providers already making a difference. Visit DutchTest.com today. Welcome back to the Dutch Podcast.
One thing that I'm curious about is whether you were also taking other methyl supportive nutrients at baseline. Do you know, magnesium, or did you have other things that you're regularly taking?
I take magnesium regularly, and to be honest, as much as they say it helps COMT, and I'm sure it does, I've never seen it move the meter in terms of...
It'd be interesting to see you on a baseline on no supplements, track your methylation there. But I think this is really interesting because if you have a patient that you do a baseline on and their methylation activity is strained, whether it's male or female, you're going to be putting more estrogens into the system, whether it's through, like in this case, something to boost testosterone, or whether it's through estrogen supplementation in a
Right.
female, consideration of like a patient's baseline ability to go through phase 1 and phase 2 metabolism of estrogens is a really good thing to be thinking about. And in this case, I mean, you could argue that if you saw this 20% baseline methylation, our team generally, like when you're looking at that slider bar on a Dutch test, there's a range that's green, that's 20 to 80, as far as the population percentile. If you're below 20 or above 80, with methylation, it's really below 20 that we're worried about. That's when we would say you should intervene. So with this patient, like with this case, if someone came in the office, you could even argue that maybe you should get them on a methyl donor in step 1. I mean, I love this because we were able to measure each impact step by step. But from a clinical perspective, you might think, let me add DIM and a methyl support right off the bat.
Yeah.
In order to avoid that time frame where you'd retest and have to add more.
Yeah, and I would have assumed before that whatever those metabolism patterns look like, that they wouldn't tend to shift around a lot as you put more hormone into the system.
Right.
And I was just, at least for me, was pretty wrong
Surprising.
on how that looked. So I think, preemptive support when you're on the lower side is not a bad idea, but it also shows that it is kind of helpful to retest after you get there, to see because you could feel great because of, in a female's case, the estrogen, in a male's case, the testosterone or whatever. But if you have downstream things going on, one, that can mean you're not going to feel as well as you want to. But then the other thing is again, this risk of, whether it's prostate cancer or breast cancer, like estrogen mediated cancers or whatever it is, if you're pushing down, 4-hydroxy pathways and you're not methylating, then, those are things worth intervention.
Definitely. I want to talk a little bit about trimethylglycine because I think there might be people who are listening who are newer to that nutrient because it's not as commonly taught in schools and in functional medicine programs, but it's also called betaine or betaine anhydrous, and it's a really fabulous methyl donor. And it's also very easy to take. Like the one that you showed, Mark, was a powder. And it's a really nice thing to add to support methylation. You can see here in this case just how effective it was at improving that phase 2 metabolism there. So I want to just put a mention out there. It's essentially an amino acid, but there's a nice product also by Metagenics. It's a creatine powder. I think it's called Creatine Up. Sorry if I'm getting that wrong. But they include betaine in it, which is a nice thing if people are on creatine anyway. It's a nice way to get a little bit of extra boost as well. So just put that. That's one that I take personally. I've taken it for a long time. It's like flavorless and so easy.
Yeah,
and it gives you a little TMG without having to add another supplement in. So a lot of good combos.
Yeah,
out
I
there.
think the DIM product we got from Ortho, they also had a TMG product. That one I liked, that it worked. The other thing in terms of TMG selection is years ago, knowing that I have crappy genetics for methylation, I don't know if I remember the name of the product, but I don't want to say it because I don't think it was damning on my intelligence, not on the product, is that it was really loaded with methyl donors, I think like SAMe and things like that, right? But when I took it, if I walked in a room that had coffee in it, like I would get like jittery, like it was interesting. I would have like a small coffee and I would get jittery. And I mentioned that in a lecture once, and then someone who's brighter than I am on that front, which is not difficult, you would be way more informed on supplements and things. But, we began to have this conversation about, your COMT still doesn't work. So if you take methyl donors in a way that's too aggressive or something like that, and maybe you could shed some light on this, is now I'm more easily making epinephrine, but I still can't get rid of it very well,
Right.
something like that. And
Yeah,
I could totally feel that. But I will say on the TMG only, I did not have that experience at all. I was separated by years, but I think that was a smarter way. I don't quite understand that. Maybe you could unlock that a little bit. I don't understand why, but it seemed to be smarter for me.
I mean, the coffee jitters is a great example. I think most of us have had that experience in that way. But I think another thing that I hear reported, what I see in this kind of same biochemistry, is, you have those people who they have an acute stressor, but then they recover from it quickly, where some other people have that same acute stressor or same level of perceived stress, and it just drags and carries on, and they can't reduce their heart rate. They can't physically calm down. They're feeling the impact of that longer. Similar to like an external stimulus like coffee, that you're getting that same
Right.
prolonged epinephrine experience.
Right. So yeah, so lots to learn from this. It was super interesting, and it was nice to get it into the peer-reviewed literature. Again, we've got population data on taking estrogen, taking more estrogen, taking estrogen with DIM, premenopausal people on DIM, and what that population data looks like. But it was just kind of a fun example to take step by step and sort of put out into the literature for people to see kind of how that works at an individual level with the individual steps, which again, not super practical, but it's super interesting.
Yeah. Now, I do think that there's a benefit to when you're putting a patient on testosterone. I want to kind of bring it back to that high level for our clinicians that are listening. Like, when should we test? What should we be looking for? And I think about it not only on, do they need some kind of clearance support, but I also think you can get clarification on, like, do they really need an aromatase inhibitor, or is DIM sufficient? I think those types of questions we should be asking, especially for men who are put on testosterone. And I think the Dutch test does a really nice job of helping to identify patients who really need to be given testosterone paired with an aromatase inhibitor, and then men who need DIM. And I think most men probably need some kind of support, just on the labs that I've seen. But
Well,
I think some men may do okay on testosterone alone without some kind of clearance support, but I think more men need it than not.
yeah, and I think, it's a cost benefit thing. No one wants to test more than they have to. There's a cost to that, but there's also a cost, there's a cost financially and biologically to taking something you don't need. So if you if you think you need DIM and you don't, I don't think it makes sense to take it. So it's nice to test and see that. I will say, in terms of aromatase inhibition, which we see a lot of, and I'm not rendering judgment on that, it's just sometimes people don't need it, is I took it, I got a prescription from my doctor just sort of for fun to see what it would look like on that. And so I took it for like 2 days, and that drug, that 1.7 estradiol, that's the thing that pulled it back to sort of its baseline value. So you can take that for what it's worth, knowing herbs and supplements and things like that are powerful, but pharmaceutical intervention, usually can't be matched that way. And that is a two-edged sword, right? You don't want to overdo lowering your estrogen. You don't want to take chemicals you don't need. And even things like DIM, we urge caution on that, because if you 2-hydroxylate things like polyaromatic hydrocarbons and toxins and things, they get more toxic. So you don't want to just shove something at everybody most of the time. Hey, I live near Portland. We want to shove vitamin D probably towards everybody this time of year. But for the most part, we don't want to give testosterone to everyone unless they need it. We don't, on and on it goes throughout the whole sort of cascade of things that are possible. And that's, I think, the value of testing, and a test like ours that looks more deeply into what the hormone levels look like, as well as what your body's doing with it. So
Definitely. Now, just kind of in final closure here, if practitioners are listening and they're putting men or even women on testosterone therapy, can you describe what you'd recommend from a timing perspective of, like, do they always need to do a baseline? And if not, how do you know when to do it and when to not do it? And then how long into therapy should they do a retest?
yeah, it's a good question. Not a one size fits all.
Of course.
So if I have a serum value and I have symptoms that overlay well, and I know I'm heading down a testosterone path, whether it's giving DHEA to a woman, giving testosterone to a woman, giving HCG, testosterone, whatever that is, you don't have to necessarily do a Dutch test to complement that. I think it really, really helps to complement it, but you don't necessarily want to fire that bullet 3 times, because that gets expensive. I think in some cases, if money's not as much of an issue, it is really nice to test before. Because if you test before and the guy has some interesting metabolism, or his cortisol's going crazy, you got to know you're not going to succeed with that guy until you address those issues. Having said that, if you get the testosterone up and you go sort of doing the snooping of that sort later, once the testosterone is up and seeing the impact of that, that can be a reasonable strategy as well. You're just going to intervene on some of those things late. Like for me, I could have hit methylation early. Why wouldn't I? That was only going to help it to be more effective. But the dim piece was not evident until we added in the extra testosterone production. So, but in terms of timing, once you're on therapy, I like the combination of using a serum test when I think I need another dose, meaning how low do I get? So when I'm ready for pellet insertion or at the tail end of my injection, or whatever it is. And I like the idea of using urine at the midway point. So pellets is the easiest one because it's so stinking long, right? So if you have a pellet every, what is it, 3 months, 4 months? Let's just say 4, makes math easy. At 4 months, at 2 months, I like the idea of this is not the max, but this is a hefty value of testosterone where I'm going to see how much estrogen I'm making and all of that. You'd miss that if you waited till the nadir at that low point. So
Right.
on an injection,
Yeah.
same thing, like midway between the doses, I think makes a lot of sense. And I think there's always added value of doing it before and after. And I think as long as you have really clear picture of the fact that it's a necessary treatment based on the serum result, then I think doing it after the fact, like in a woman, man, looking at 5-alpha metabolism is pretty nice because if you're going to give her something that's going to then turn into a whole bunch of DHT, I'd like to know that beforehand because you're going to
Totally.
get some negative effects
Yeah.
on
Let's talk a bit more
high
about that.
androgen symptoms. Yeah,
A ton of women are taking testosterone. It's like
right.
being talked about. It's still off label, so it's not FDA approved. However, a lot of women are utilizing it. It's FDA approved for low libido, but that's it really. So,
Yeah,
and women are using it for a variety of other symptoms. It's being prescribed. And what I'm seeing is typically a T-gel, right? So sometimes pellet therapy, but I think the T-gel is an easy way, or like the androgel, to apply it on a
right.
regular basis. They're using 1/10 the dose for men. And that's what I'm seeing most typically prescribed. When I took that Harvard course, women's health course, which just happened again this year, they cover that again. Like it's being taught at all the institutions for women. So what we're talking about here is like some women, well, one, women have a lot of fear about testosterone, I think, because they're afraid of turning into a man.
Right.
Ultimately,
Right.
growing hair in the wrong places, getting acne, those androgenic symptoms. And so those are kind of undesirable side effects. And we know that we can look at metabolites, which when it comes to androgens, metabolites are actually stronger than that parent hormone. So we can see
Right.
people's preference on whether they're more likely to make more of that or an average amount of that or less of that. And you can look at that ahead of time with endogenously produced
Right.
androgens and really get an idea of, is that 5 or that 1/10 dose, that little pea-sized dose, going to be sufficient, or are they going to need more? Or are they going to need less?
Right. Yeah, I think your actual levels matter, which you can grab in serum or you can grab, from a Dutch test. And then what your body does with it is, as you said, particularly important for testosterone because DHT is 3 to 4 times as potent as testosterone. So you could have a woman with the same testosterone dose, same testosterone level, that based on whether she's a 5-alpha pusher or a 5-beta pusher, which is non-androgenic, you could really have a 3 times difference in terms of dose of the DHT going on at the tissue level. And that's why we like to look at 5-alpha androstenediol. That's why we pulled it to the front page of our report, is looking at those levels, looking at the 5-alpha preference, which then relates to insulin sensitivities. And you keep putting the picture together more comprehensively, but knowing that going in can be really helpful. If you're going to wait 3 or 4 months, I mean, I to be honest with you, I don't know how long it takes a woman who's got too much DHT to get acne and facial hair growth and that sort of thing. But it's a pretty good way to have a former client instead of a client if you get that wrong.
That's a good point.
And because it's not like you can reverse that in 5 minutes.
Right. Yeah, that stuff takes a long time to reverse. Now, I think the one other thing that I wanted to point out around that, if you're utilizing a transdermal testosterone, is that you're going to have like an up and down pattern pharmacokinetically with that daily application. So I think when you're looking at injections, which last days, or you look at a pellet, which lasts months, you can measure midway and get a pretty steady stream. But I think about, and we don't recommend utilizing the Dutch test for monitoring dosing of testosterone because serum is great. But is that different in the transdermal world because of an up and down pharmacokinetic pattern where like a 4-spot urine test would be advantageous?
I think we could oversell what we do a little bit with that because the pattern's actually not bad. And that's in
Yeah.
contrast
Okay.
to estrogen. Like that's one
Okay.
of the
Right.
reasons why serum kind of stinks for estrogen creams and gels is because you can take your cream or gel and you can hit a number in serum of say 80 or whatever. Um, and then you can also hit a number of 15 and you don't know which number you're going to get depending on the timing because it's really individualized. And it's not even the same necessarily from day to day, depending on, you know, all kinds of variables, meaning the up and down pattern is a real problem for serum with estrogen when it's not a patch and it's a cream or a gel. And with testosterone, it seems to be pretty steady. So you can get a decent value that you can hang your hat on, which is a pretty good segue into the publication that we've got coming
Yes.
out
Thank you.
in
You
just
provided exactly the info I was hoping
in
for.
these next couple weeks because we went and looked and we said, hey, how well does the serum dance with this clinical picture of all of the things that happen when you're on testosterone? Because there is a fair amount, well, I should say in the allopathic community, there's almost no confusion on this topic, but they might be confused on other aspects of HRT and sometimes like significantly so. But in the functional medicine space, where there's been such a history of pro saliva education, not generally, but as it relates to monitoring hormone creams and gels where those values are exaggerated above serum, we did a deep dive into that and looked at every study we could find to see whether the serum values seem to match up very consistently with those clinical outcomes, and then contrasted that with urine, with saliva, but particularly with saliva, and also looked at dried blood spots in urine a little bit. But that is going to be an exciting publication for, I think super helpful for people to just systematically walk through the data. And then we
Yeah.
also published some original research within that review, which was looking at saliva values as they go up in women when you're on therapy, meaning looking at hundreds of women that are at normal levels, elevated values, and then super elevated values. Do their high androgen symptoms track with that? And as it turns out, which is what we've seen before in the literature, but not actually, there's not that much on that particular point in the literature, is there was no correlation between how high the saliva value was and a woman's likelihood of saying, hey, I've got acne, facial hair, thinning scalp hair, that sort of thing.
Right. Yeah, I mean, we'll spend time on the pod breaking that down. So we are going to be talking about that later once that paper is out and you guys can look at it. Because I do think that it's really interesting, particularly if you've been utilizing saliva for monitoring testosterone therapy, which, like you said, we see in the conventional world. In fact, one of the reviewers commented that no one does that. But as we see in the functional medicine space, people do. So it really, and I think this just leans on Dutch's approach to healthcare and science and hormones, which is that we want to look to the literature. We want to be part of the evidence base and like have our data subjected to peer review because we want to make sure that we're leading clinicians down the right conclusion. But I think it's also a time where a lot of integrative medicine, like we've been handed down information from our elders. And that oftentimes came from clinical observation. A lot of times we got it right. Like I think about probiotics or leaky gut syndrome, which was kind of that classic case. Now we know that gut hyperpermeability predisposes to things like autoimmunity. Like we have the scientific connections, but it's our job to be constantly reevaluating the inherited knowledge through evidence wherever possible. And I think really that's where we took this approach with this paper. We didn't go into it thinking, let's prove urine is the best, because we just don't feel that way based upon what we know. We think serum is the best. But instead, let's look at the evidence that's out there for the other means that are being utilized in integrative medicine, because maybe we can help people improve their practices.
Yeah, and specifically for testosterone therapy, serum seems to track best with the clinical data. And as we've said, I think our position is that a urine test makes a very nice complementary product for that. And then when you shift into the estrogen, then it gets really interesting because that up and down pattern in serum is so fast, the urine may actually be a better option for the primary question of did I get the dose right? And then also is interesting in a complementary sense of looking at HPA axis, looking at phase 1 estrogen metabolism, methylation, and so forth. And there's still a lot of research that needs to be done on that question of dosing and testing, and because that's a big question. So what we wanted to do in this most recent publication that's coming out like tomorrow-ish, is really look at the data on like what we can push forward with and learn more about, and what we need to leave behind. And that's an area where I think our industry serves itself well by leaving that model behind that says these high values in saliva have clinical utility in that context. And I don't think it's actually that prevalent for testosterone. Somehow our industry has seemed to have said just pragmatically like, oh, that doesn't really work. But then they lean more into that on the estrogen side of it. The reason we started with testosterone in terms of that publication is just there is a lot of data, clinical
Yeah, there's
data
so
that
much
says,
data.
hey, we can put this model, and I don't mean this single model, serum, saliva, urine, and blood spot. And I've started to really think about that I think we spend too much time saying which test is better. And I think it's a better mental process to take a test and say, am I better having this value or having nothing when it
Yeah,
comes
that's
to
a great
that
way to put
question
it.
of
Yeah.
dosage adjustment? And there are certain situations, anyways, I think that's a better way to ask that question. It's not about, market share and who's doing saliva testing and urine and whatever. It just needs isolated to, and I think in this case, what we showed is having a saliva value when you're on topical testosterone is more prone to pull you in a direction that's misleading than it is to be helpful. And it's probably better,
Mhm.
you're probably better off having nothing than having that value. And so I
Right.
think going through that mental exercise of looking at those studies and finding that there really aren't any studies, that this key finding is, can you find a study where what happens clinically exceeds what you would predict would happen just by looking at the serum results? So you see the serum
Totally.
goes up, and then you see, oh, here are the things that happen. We don't see any studies that we could find where we said, well, the serum value didn't really move, but man, the bones improve, or the sexual function improved, or whatever it is. They seem to dance together like relatively well and consistently across every parameter that we could find that's been studied, which again is most robust for testosterone. But when you
Right.
start digging into estrogen, you find a parallel case. It just, all you've got there are hot flashes, vaginal atrophy, and bone mineral density.
Wow.
You don't have this whole bigger list, but it still paints a fairly consistent picture. But it's a confusing one, and one that hasn't been laid out in the literature, which is why
Mhm.
we chose to
Yeah.
start with testosterone and do that as thoroughly as we could.
I want to end with just a funny story because, I think this is something that speaks to why this topic is important. And, the reason that I really like working with Dutch is the desire to get things right scientifically. And one of the things that I'll just never forget, thankfully you still hired me, was when I came in to kind of interview for the job. One of the first questions I asked, which I realize now what a dumb question that was. So thanks for giving me the
I have
grace on
no
that
idea where you're
one.
going with this. So this is memory lane. So go ahead.
Oh, good. Well, it stuck in my brain. I'm glad you forgot it. But I remember we were sitting outside the picnic table and I said, hey, Mark, have you ever thought about or why are you not offering salivary testing for reproductive hormones? Because you have the capacity. You already collect the saliva to measure cortisol. You have all the equipment in the lab. You're processing the samples. Don't you realize that there's a market equal to the size of the urine testing out there for saliva? And you said, well, because I don't want to mislead people, And I was like, okay, I have some learning to do, and that's a pretty good reason to not do it. But I just think that's really important. Like I know that, and you've gotten into this before. And when we released the paper, you wrote a piece kind of about this transition for you. It's our responsibility to reevaluate science. It's clinicians' responsibility to be constantly reevaluating science and the body of evidence and to make decisions that are in the best interest of our patients. And so I think it just brings me back to that. In integrative medicine, if you're doing something because you were taught to do that and you don't verify that that's the best way, we all want to trust our teachers, but we should be checking to make sure we're doing the right thing.
Yeah.
And I think when things come up that are questioned, it's okay. There's a lot in science that we don't know. It's okay to say we don't know or we don't have enough data. We need to get more data to really answer that question. Yeah. But one thing you mentioned is that there's some things, it's hard to prove something is true, but it's easier to prove that something is not true.
Yeah.
With data and science. And I think this is one of those cases.
Yeah, I think, just in our world today, like really nailing down what is absolutely true on a host of topics can be rather difficult.
Yeah.
But our quest for that is so much easier if we can take ideas where we can fairly conclusively say, okay, this model doesn't work very well. And I think it's a space for us to help educate in. And it's hard to not be biased in those conversations. And I think
Right.
each test has its purposes, but these topics get so confusing because, with saliva testing, like there are also differences in methodologies. So if you
Yes.
say, does saliva work for a baseline test? Well, we like urine because you get all this metabolite information. But for the hormones itself, particularly for cortisol, of course, that's why we use it. That's also hugely method dependent, that it depends on, doing accurate testing is really important. But then because it's so misapplied to the HRT scenarios, I think it's hard to not mislead people on that without this re-education process that I think we're still sort of in the middle of as an industry. So it keeps it interesting, but we've got a lot of work to do to continue finding out what is true and how to, when to best leverage saliva testing, when to best leverage urine testing and serum. And I think, a combination of those in a lot of cases really gives you, a great place to make really good decisions. So.
Right, definitely. And I mean, so if you, if you have questions around this, reach out to us at Dutch because we love to talk about it. And we'd love to hear from you. But Mark, I really appreciate you joining me today on the pod. And again, you guys can visit dutchtest.com/research. And right now we're featuring this IMCJ case study right on that page. So you can click if you want to read the case study. We have a synopsis of it and on the blog, and then you can link to the full PDF there if you're interested.
And you're a co-author, so thank you for your help with it and for discussing the topic. I think it's super interesting and excited for everyone to see the other publications that we have rolling out as well, because I think those are going to create some great conversations.
Totally agree. Thank you, guys.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.